meeting of the Senate Healthcare Committee to order. Before we get started, I want to thank our Sergeant at Arms, Terry Barnhart. Where's Terry? There you are in the back. John Boyette, Gary Bridges, Keith Cannon, Mike Harris, and then Cherie Hedrick. Thank y'all. We got some pages here with us this morning. I think this is y'all's last morning. If y'all could just come up to the microphone and introduce yourself and tell us who your sponsor is.
Hi, my name is Carter Gardner. I'm from Charlotte, and I'm sponsored by Senator Bradley.
Hi, my name is Aaliyah Ryder. I'm from Raleigh, and my sponsor is Senator Sanderson.
Hello, my name is Danica Edelman. I am from Raleigh, and my sponsor is Senator Adcock.
My name is Jalen Sabrin. I'm from Lewisburg, North Carolina, and my senator is Senator Barnes.
I'm Atticus Kenny. I'm from Durham, and my sponsor is Senator Chitlick.
Thank y'all. Thank y'all for being here this week. I hope you've had a great week. I think it's been an exciting week, certainly, and hopefully y'all picked a good time to be up here and had a chance to spend some time with the members and watch and learn and help us out. So thank y'all for being here today. All right, we have 3 bills on the agenda this morning. I'm going to go out of order. I think we moved it a little bit. We're going to call up Senate Bill 403, Medicaid work requirements, and recognize Senator Hayes to present.
Thank you, Mr. Chairman, members of the committee. Work requirements for Medicaid have always been intended to be a part of our plan as we have submitted to CMS. The language in this and previous had always said that when work requirements become available or it intends that CMS would approve them, that the state of North Carolina would seek for what are the available work requirements on Medicaid. Obviously, there's been a change in CMS, and we believe there's plenty of indication that their opinion on work requirements are different than they have historically been. So this actually implements that and tells the department to apply for the work requirements to negotiate with CMS and to implement whatever is approved by the feds. I'll be happy to answer any questions.
Thank you, Senator Hayes. Any questions or comments from the committee? Senator Mayfield.
Thank you, Mr. Chair. So, Senator Hayes, just so I'm clear, so you said that, so our law has already said that if CMS requires work requirements, then we need to require work requirements, right? This bill just directs DHHS to get that process started. Is that right?
I would not categorize it as CMS requires work requirements. It is to the extent that they would be allowable under CMS. We would take advantage of that as a state.
And so this.
Senator Mayfield, a follow-up?
Yes, thank you. Sorry. Okay, so tell me again what this bill does.
So this bill asks for them to go ahead and to apply and then to implement those work requirements that are approved by CMS.
Okay, thank you.
Any further questions or comments from the committee? Senator Waddell.
Thank you. I think we've had something similar to this early on concerning the work requirements.
So we've had, best I recall, multiple conversations about work requirements and others. To this point, the negotiations with CMS have not approved work requirements for the state of North Carolina.
This is
Well,
this is sort of ambiguous because it does not give any specificity to what they are requiring. So may I recommend that we do a study first? And the reason I say that, in the past, the work requirements were really strenuous for some of our seniors who own Medicaid. So we got to be careful with that.
Thank you, Mr. Chairman. I just don't see any, I think it's clear that this is not, CMS has put out some clear regulation as to what work requirements they will approve if a state were to apply for them. And by that definition, I don't know what a study could render you about guessing what the, I don't think they'll comply with a, let's go survey them and say, what would you let us do if we asked you? There is multiple opportunities for the state and the state legislature, once that is submitted, once that is negotiated and approved with CMS, to make changes to the work requirements that we put in prior to implementation. These are not quick fixes, but this would say that barring that action of the General Assembly, we will implement what we ultimately negotiate.
Any further questions? Senator Garrett.
Question for Senator Heiss.
Ask for a question.
Senator Heiss, I appreciate we're trying to speed this along while there still is a CMS. But leaving that aside, I just have has any state applied to implement work requirements since the change in administration, or has CMS issued anything that broadcasts to the world that they're willing to approve work requirements, or are we just making an assumption because the administration changed?
Staff may be able to answer if any states have applied and been approved. I don't know that. There has been clear indication from comments made from the administration and from, I believe Dr. Oz is now the new head of the CMS that's there, of their support of work requirements. And that's more what we're going on. They have not, CMS has not made an official statement or position. And if we submit this and the department goes up there and they say we don't, then that's what we did. We don't allow any work requirements.
Senator Garrett for a follow-up question.
No, I'd just like to take Senator Heiss up on his offer to see if staff knows of any.
Staff.
Yes, thank you. Jennifer Hillman, Legislative Analysis Division. I am aware that states have been working on plans for work requirements, but I'm not aware that any state has submitted a request for work requirements. I'm also not aware of CMS yet sending any guidance or official communications to states about opportunities to implement work requirements.
Thank you, Jennifer. Any further questions or comments from the committee? Senator Moffitt.
Thank you, Mr. Chair. I'd like to thank Senator Heiss for bringing this bill forward. I've been involved in employment for almost 40 years, and we have a workforce that is just disconnected from really society in general. And I think a lot of these programs that we've created out of well-intentioned reasons has actually created a problem with getting people actively engaged into the workforce. And having a job and having responsibilities and having some guardrails of accountability is not a bad thing. I think it's good. Hard work is good for the soul. I applaud the effort, and I think we should broaden it to other programs as well.
Senator Mayfield recognized for a question.
Yeah, just want to point out, just for the sake of the record, that of course the vast majority of people on Medicaid already do have jobs.
And if I can,
Senator Oz recommend.
To also comment on that is accurate. And I will also say, with the concerns about senior citizens, using the traditional definition of 65 and older, I'm not aware of any work requirement that applies to dual eligibles, because at that point they would be on Medicare as well as Medicaid, and they would have, and their income for Medicare for Social Security does count towards their eligibility requirements, and for SA and other things we have. I am not aware of anywhere that seniors would be under a work requirement as dual eligibles.
All right, Senator Corbin.
Just a brief comment. Thanks, Senator Heiss, for bringing this forward. As you know, among a lot of us, worked very hard to get Medicaid expansion across the finish line. I think it was the right thing to do, and I support this bill motion at the appropriate time, Mr. Chair.
Thank you. Any further comments or discussion from the committee? Seeing none, I believe we have a motion for a favorable report to the bill with a referral to rules. Is that correct, Senator Corbin? All those in favor, please signify by saying aye.
Aye.
Any opposed? All right, motion passes.
Thank you, Mr. Chairman, committee.
Thank you, Senator House.
At this time, the chair recognizes Senator Sari to discuss Senate Bill 336. So you want to do that one first?
Yes, we'll do that first.
336.
Thank you, Senator Bergen. Senate Bill 336. This is a combination of two pieces of legislation, or two proposals that we've seen in the prior session. The first part is an interstate medical license compact. It is a comprehensive compact that would allow North Carolina doctors to participate participate in with other states around the nation. We've seen other compacts. In fact, I think in rules this morning we passed out the PA compact. I believe we have a social work compact and others, and staff can run down the full list. It's becoming a more prevalent concept. The other piece of the bill, which I think is more substantive and a larger change, would be a pathway for licensure for internationally trained physicians that are located here in North Carolina. Right now, and if I could sum the bill down very quickly, if you are a doctor who's received a certain level of medical training and education in an international school or international country, another country, you might lack an American residency. If you lack that American residency, then there's a circumstance where you could not become licensed to practice medicine here in North Carolina. What this does is sets forth a list of criteria and a limited set of circumstances where the person that would lack that American residency but otherwise has a valid license to practice medicine, has obtained a medical degree from an accredited university, has a certain length of practice time in that country, is otherwise in a good standing, and has come here and located for various reasons, would have a pathway to practice either in a hospital setting or subject to supervision in a rural physician's practice. This is in the theme that we've talked about in the Senate Healthcare Committee of access to care, getting more providers into our communities and especially into our rural settings. I'm glad to answer any questions. I will note that the current iteration of the bill was part of a negotiation that occurred in House Bill 125 last session, the conference reports. There's been a lot of stakeholder feedback with the medical board and other groups prior to this. So it did conform a lot of those changes to carry over here today. And there is an amendment that's technical I'd like to send forth to. Mr. Chair, no, the amendment is S336AB-20 version 2, and again, it's substantially the same as the explanation I just gave, but again, makes some of the same provisions. But I would offer that for your consideration. Glad to answer any questions or discussion.
Any questions about the amendment? All in favor say aye. Any opposed? Okay, thank you. Now the bill is back before you. Any questions about the bill? Senator Moffitt.
Thank you, Mr. Chair. Senator Sawery, on the International Physician Employee License, so when it comes to accreditation, not all medical schools globally are accredited, as I recall. Is that correct?
Thank you, Mr. Chair. Yes, that is correct. So in the bill itself, it's a school that's eligible under the Education Commission for Foreign Medical Graduates. There's a published list of which accredited schools are recognized and allowed.
Follow up. So I know, and this is about 30 years ago, we would actually recruit doctors from foreign countries where their education took place in a institution that was not accredited, but we could park them in Canada for a year or two, and then once they had that practical experience in Canada, we could bring them into the United States. Does this eliminate that?
So again, it provides a limited pathway with respect to the residency, and I can't speak to the Canadian issue that you talked about. But what this would do is for a period of time, if they've been practicing, and I think it's for at least 5 years in a country, in a jurisdiction, and have otherwise those credentials, they can come in that setting. I think one of the things that's a little strange about this is a person without a residency can come and teach at one of our medical schools, can be a professor, actually teach some of the subjects that our students are relying on. I think we've seen that in some cases, but what they can't do is actually practice medicine. So what it's doing is just providing a pathway other than the American residency to practice.
I'm good, thank you.
Senator Waddell.
Yeah, I have some constituents in my area who finished medical school in foreign countries, and I think if this bill, the way it's crafted, would help them, but I see some barriers here because it says they would pay fees, complete the registration, so it's just not an automatic become eligible to practice.
Sir, sorry.
That's correct. I think I mean and I can't speak to the exact number of the fees that a regular doctor would pay, but I think every profession where there's a licensing regime, there's an obligation to make payment of some type in order to obtain that. So I think this would be consistent in line with what's expected of anybody else that's seeking to obtain a license to practice medicine in North Carolina.
Follow up?
You did mention in many of the rural areas, because one of the meetings that I attended had physicians who were in some of those war-torn countries, and they were coming here not even able to practice. They were doing like just day jobs, because when one of the planes that was leaving one of the countries told them, everybody who was able to get on this plane now, you can come to the United States. If not, you're going to be left behind. And so many of them, in fact 3 of them, were not able to get jobs. So if this bill, the way it's written, can be implemented, I think it would be helpful to them.
Thank you, Senator Waddell. And I think there might be a speaker in the audience that can talk specifically on the refugee component of this, but that is a population that's in mind with this particular bill. There are people that are qualified and trained and excellent doctors are living here in North Carolina that simply have regulatory burdens to get over in order to contribute to the practice of medicine and care in North Carolina. They want to do what they've been trained to do, and this hopefully allows a pathway to make that happen. And again, I'm in Johnston County. Johnston County is a healthcare desert for a lot of different practice groups. If Johnston County is a healthcare desert, I can't imagine what some other communities are suffering from. So if we can find a way to get these people into these communities and providing the care that they need and deserve, I think that's a win for the state of North Carolina.
Senator Mayfield.
Thank you, Mr. Chair. Senator Sari, so my understanding is the language that's included in the amendment is language that was agreed upon by, as you said last year, medical society, medical board, all the medical people are good with that language.
I am not going to say that they are in agreement or good with it, or endorsing this. I'm going to suggest that there was a series of meetings where there was a lot of input that was made into this particular bill. I have not heard from the medical board or medical society about this particular piece of legislation this cycle. I'm hopeful that maybe some of the hard work we did last year carries over, and perhaps we can see some smooth sailing with the bill this time.
They kind of sort of like it.
Okay.
I don't even know if they kind of sort of like it.
Follow up, Mr. Chair.
Senator Mayfield.
Thank you. Maybe there's somebody in the audience from those organizations that can speak to this. The other question I have is, and I haven't had a chance to read the amendment closely or at all, but is there a pathway to full independent practice by these physicians, or do they always need to be practicing under the supervision of a U.S. trained physician?
There's not within this bill itself a pathway for independent practice.
Follow up. Senator Moffitt, did you have a question?
Just a comment. Wanted to let the bill sponsor know that I read through Section 3 regarding the internationally trained physicians. It's well done. It answers a lot of my questions. Thank you.
Very good. Any other questions? We do have 2 speakers. Jonathan Wolfson is first, and then Sid Rad is going to be second if you'll be ready. If you'll identify yourself, the organization you represent, or who you are.
Mr. Chairman, Jonathan Wolfson, Chief Legal Officer and Policy Director at Cicero Action in support of the bill. Thank you so much, Mr. Sponsor, for sponsoring this bill, and members for letting me be here today. I've had the privilege of working on similar legislation in a number of states around the country. This is one of those bipartisan pieces of legislation because the doctor shortage doesn't exist in just red or blue states. It doesn't exist in just red or blue parts of states. It exists across the country. And North Carolina is facing a shortage of about 7,000 doctors over the next decade, and this is one piece of the solution to addressing that shortage. And I think that this legislation follows the lead of states like Virginia and Massachusetts and Florida and Tennessee that have recognized that doctors who are licensed outside the United States who want to come practice in North Carolina should have that opportunity to do so. These doctors are going to be given provisional licenses that limit what they can do, where they can practice for a period of time, and ultimately gives them a pathway to full licensure. And that is a really great opportunity for those doctors to come to North Carolina, serve patients who otherwise wouldn't have access to that care. And so I think that this is an important piece of legislation. It's one that ultimately can provide benefit to those doctors themselves, but also also to medical students in the United States, because as the sponsor mentioned, right now, in order for those doctors to get licensed here, they have to come and get residency. Well, about 1,000 kids graduate from U.S. medical schools every year and don't match to a residency. And so those kids are competing with doctors from outside the United States every year for residency slots. And ultimately, we're limiting the number of slots that people can get to then get into the practice. So this really does open pathways for more people to practice medicine in North Carolina, and I think that this is a very good bill. Happy to answer any questions about what other states are doing or the unique features of this legislation. Appreciate your opportunity to be here. Thanks.
Thank you, sir. Appreciate the comments. Okay, Sid. Is it Sid Rad?
Rao.
Thank you, sir.
Good morning, Senators. My name is Dr. Sid Rao. I'm an endovascular specialist who's been practicing in the Raleigh area for over 2 decades now. I'm a board member of the Triangle Indian American Physicians Society, TIPS. TIPS represents close to 400 physician members, both international medical graduates, IMGs, who have completed comparative U.S. residency and fellowship training programs, as well as U.S.-born and trained physicians of Indian origin. So I just want to thank Senators Adcock, Senators Sori, and the committee for giving us this chance to address this specific issue of ITPs, internationally trained physicians. So TIPS has been at the forefront of this issue. We very much appreciate the work of this committee in addressing concerns to access to healthcare, especially in rural North Carolina. However, as it's worded right now, we do have a few concerns. Number one, clarity in the location of employment, training, and supervision. Under these 2 subheadings, scope of hospital employment, the bill does not specify whether hospital employment of ITPs is limited to rural hospitals and or urban hospitals as well. That's number one. Number 2, supervision requirements. In rural clinics, there are clear guidelines about how these physicians need to be supervised. In the hospitals, there's nothing in the bill that addresses that. Number 2, pathway to independent licensure. You do have to understand these are human beings that are coming over. There's no defined roadmap for ITPs to transition to a full and unrestricted licensure, leaving them and their U.S.-raised families to indefinite uncertainty. Number 3, employment protections. The bill does not have any safeguards for ITPs facing potential employer abuse. So these are the 3 things we wanted to address. So thank you very much. I'm happy to take any questions.
Thank you, sir. Appreciate it. Any other questions again from the committee? I said, Senator Waddell, sorry, I didn't see you.
No, at the appropriate time, I move for approval of this bill. Thank you.
Very good. I will make a comment. 2 weeks ago, I got a call from a doctor that's here working with UNC from Brazil, and we were discussing this. So it's happening all over, and we do need to be looking at this. Thank you for working on this. We do have may I state a motion for you?
Senator, Mr. Chair, before we do the motion, can I make one more comment?
Of course.
I want to clarify something that I said earlier.
Go right ahead.
The initial version of the bill did not, to answer Senator Mayfield's question, did not provide a pathway for full licensure. I believe the public just mentioned that. But the amendment does contain a provision where there is a pathway to potential full licensure. That's on page 2, line 9. But that requires an extended period of time of practicing under this license. I just want to clarify that.
That's how quick we respond to speakers that come. So thank you all for the input. That's great. Senator Waddell, a motion for a favorable report for the bill as amended, rolled into a new PCS, unfavorable to the original, with referrals to finance and rules. Does that sound okay?
Yes.
Is there a second? Have a second. All in favor say aye. Aye. Opposed? Thank you. Thank you, Senator Sarr. Next is Senate Bill 479, the SCRIPT Act. Go ahead, sir.
Thank you, Mr. Chair. Senate Bill 479, the SCRIPT Act, this is legislation that seeks to address the issue that we're seeing with PBMs, PSAOs, and the retail pharmaceutical market that we're seeing in North Carolina. There's a similar effort on the House side to address this issue. I believe that we saw that last year. This bill seeks to do some of the same things the House bill does, but it's very different. And we started on this journey, we did not want to regurgitate and try and pick some of the pieces from that. We wanted to seek to address the issues in a creative way. So I'm going to, if it's okay with Mr. Chair, I'm going to summarize the bill, as well as there's an amendment on your dashboard at the same time. Ask for a vote of the amendment or introduce the amendment, and then open up for discussion or ask for questions.
Go ahead
it's extensive. Part 1 of the bill is a new section. You'll see the reference to the word pharmacy desert, so there's recognition that some of our communities, while oftentimes you have situations where your pharmacy is your only healthcare provider in your town, might not be the case always. So we're creating an opportunity for some type of incentive agreement to exist between insurers and pharmacies where they locate in an urban or a rural pharmacy desert. We recognize that the deserts don't just exist in our rural communities, they can also exist in our our urban communities as well. The amendment that we will see within coming up actually changes the definition a little bit with respect to a pharmacy desert. So the bill as it's currently written is a 1 mile radius in an urban community, 10 mile radius in a rural community. We've expanded that to 2 miles and to 15 miles. We've also changed the definition, the population of the county to 20,000 people, which captures more counties, maybe 15 or 20 of them, as opposed to the 2 counties that were being captured in the initial bill. There is a definition, this in part 1, that's very important that carries out throughout. It's the definition of what is an independent pharmacist. That definition is still a work in progress. We are meeting with stakeholders, pharmacy groups, retailers, insurers, groups that are involved in the marketplace, and to try and craft something that works. Right now, it's a definition of 3 or less. I think the definition needs to be higher. We're working with that, and also recognition that there are different types of pharmacies that are out there, and a one-size-fits-all definition might not be the best. So that is, I would ask for some patience as we work with that. The part 2 of the bill is a transparency and freedom of contract provision with respect to a PSAO. So PSAO is an organization that contracts with the pharmacies and wholesalers on one particular side of this marketplace. Is something that I think gets omitted from a lot of these conversations. The PSAO is we spend a lot of time talking about transparency, pricing transparency, business transparency in this committee. This addresses PSAO transparency. Within the amendment that you'll see as well, it creates a fiduciary duty for PSAOs in performing its duties with respect to a pharmacy. You'll see a PBM fiduciary duty in a later section. Part 3 addresses PBM transparency reimbursement and also creates a fiduciary duty with respect to the PBMs and the insurers and the insured parties in this particular case. It includes a report on spread pricing. This is something that puts us in line with 25 other states around us. It requires PBMs to report to the Commissioner of Insurance certain information on an annual basis. The amendment that's included in your packet does include some feedback from the industry groups about practice and what information they have available and can report. So we did incorporate a lot of stakeholder input into this particular section. Part 4 of the legislation clarifies anti-steering regulations with respect to PBMs. It is within the pharmacy of choice statutes shall apply to PBMs that contract and insure in the same manner as it applies, It applies to PBMs that contract and insure in the same manner that it applies to an insurer itself. Right now there's anti-steering provisions with insurers. This carries over to PBMs as well. Part 5 allows independent pharmacies to redirect prescriptions. This was something that was fascinating to me that I learned during this process. If I go to Senator Bergen's pharmacy and I have a prescription for Zyrtec or something else, an allergy medicine, since it's pollen season, and his acquisition cost or the contracted cost for that particular prescription is a negative amount, North Carolina law would require and mandate him to fill that prescription and sell that product to me at a loss. I cannot get over the fact that North Carolina law requires him to do something at a loss to his business. What this does is allows the independent pharmacist to redirect to another pharmacy, to a mail order pharmacy, to somebody else that might not sell it at a loss, but allows them to honor their professional responsibilities as a pharmacy in North Carolina. I think this is a powerful tool that allows some of our retail pharmacists and independent pharmacists to have control back over their business and not be mandated to do something under North Carolina law. Part 6 is strengthening pharmacy audit protections. One complaint we hear from our independent retail pharmacists is the audits they go through. This is a very comprehensive plan in place. It's going to be in statute with respect to how audits work. Part 7, deals with pharmacy benefit manager affiliates, PBM affiliates, and non-affiliate pharmacies about how the pricing model works. One complaint we hear is that some of these PBMs and retail pharmacy groups are vertically integrated bills seek to address this by putting a pricing mechanism in place, something called NADAC or MAC or some type of list that you can point to. What our language says instead is that you must level the playing field in this instance and not use some anti-competitive monopolistic power in order to hurt retail or independent pharmacists to the benefit of ones that you're affiliated with. Part 8 of the bill provides that consumers are going to receive the benefit of the pharmacy rebates. This section requires when calculating an insurer's defined cost sharing for a covered prescription drug at the point of sale, an insurer offering a health benefit plan shall base the calculation on the price of the prescription drug after taking into account all pharmacy rebates associated with that prescription drug. And then, and this is important, it requires that calculation shall be reduced by an amount equal to 90% of all rebates received or to be received in conjunction with the dispensing or administration of the prescription drug. We hear oftentimes about how the rebate games are played back and forth within the market. This makes sure the rebates go back and the benefit goes to the consumer or to the insurance company, the actual payor in this context. There is a new definition of a rebate, something that I've learned during this process after a series of meetings every week is the importance of definitions. And I figure I should know that, but the amendment states that a rebate is defined as a formulary discount or price concession attributable to the utilization of prescription drugs in the state and that is paid by a manufacturer to a PBM. Part 10 of the bill is a prescription drug transparency provision with respect to the pharmaceutical companies. The amendment addresses some of the confidentiality concerns of trade secrets in place, but also requires a report when a manufacturer must notify interested parties of certain price increases in expensive drugs. And the final piece, which is in the amendment, is Section 11. It requires a reporting by the Board of Pharmacy that details the current number of licensed pharmacies in the state, the number of independent pharmacies that have opened the preceding 5 years, the number of chains that have opened the preceding 5 years, the number of independent pharmacies that have closed in the preceding 5 years, and the number of chain pharmacies that have closed in the preceding 5 years. We hear a lot about the health of our independent and pharmacies across the state of North Carolina. Numbers get tossed around on both sides of the issue, and I think it's helpful for us as we continue to have this conversation with accurate information at our fingertips that's been vetted by the Board of Pharmacy who's actually seeing this. This is a very comprehensive bill. It's been worked on at length with lots of stakeholders. This is a first stop for several committees where we're continuing to work. I want to give a major thanks to staff, Madison, who's over there, who's been working very, very hard on this, and my co-sponsor on this bill, and I'm glad to answer any questions. And but before doing that, would submit that the amendment is before you for consideration.
We have a motion for the adoption of Amendment ABC-23. Is there a second? Have a second from Senator Waddell. Any discussion about that? All in favor say aye. Any opposed? Okay. Any other discussion about the bill before I open it up from you?
No further.
All right, open it up for discussion. Senator Moffitt.
Thank you, Mr. Chair. Senator Sawrey, take me back to, I guess, what you're talking about regarding the rules compelling a pharmacist to fill a prescription at a loss. Did I hear that correctly?
Sorry.
That is correct. North Carolina, we if I go to Senator Moffitt's pharmacy and you have the Zyrtec in stock and I have a prescription for it and I hand you the prescription, then you are obligated to dispense that drug to me. If the reimbursement rate that my insurer has with you is less than what the PBM is going to reimburse you at, then you might take a loss on that drug. When I talk to independent pharmacists in my district and around the state, they have any number of examples where their reimbursement rate is 20%, 30% less than what their acquisition cost is. Candidly, I think it's against every tenet of free market capitalism that somebody should be able to choose what products to offer and to sell at a rate. But North Carolina law is mandating they do something like that, which is, I was shocked to hear that.
Follow up. How would that not be construed as a regulatory taking?
Sorry.
Great question. Hopefully we can address that in the bill.
Very good.
Senator Hayes.
Thank you, Mr. President. And Senator, I say up front, I like where this is going in those kind of things. I did want to ask one first question on this. Isn't the pharmacy selling it at that rate because there is a contractual agreement between the pharmacist and at the rate they would sell it?
Sir, sorry.
So it's not that sell. There is not a price they have to sell at. They have entered into an agreement with the insurance company to dispense at a particular rate. What the state law merely requires is if I show up with a prescription and you have Zyrtec in hand, you fill Zyrtec consistent with your obligations and the obligations of my insurance company.
Sorry.
That's correct. There is an obligation, but oftentimes there is a contract that's in place. I think that's one of the concerns is who are the parties that are involved in this contractual process, right? I mean, you have PSAOs on one side of the issue. I think in my conversations, there's 6 in North Carolina. Well, 3 of those PSAOs, I believe, are wholly owned by some of the drug wholesalers. So there's a question of just looking at the marketplace as a whole is where are we landing on this? And on the PBM issue as well, I think there's the transparency concern in place. We're trying to get around with this, and that's why we're putting the duties in place with respect to these entities to act in the interest of the parties that they're supposedly advocating for at the table here, and not necessarily their own profit motives.
Oh.
Yeah. And the last thing I'm trying to get to is, do you have a sense of, as applied, what this bill would do to the cost of the state health plan that's coming in? So do we have a sense of what we would expect to not receive in rebates, what we would expect to pay out in prescriptions versus where we are? And do we have that kind of information to kind of extrapolate what this cost would be to premiums and others of members of private insurance?
Senator House, that's a great question. So as currently written, this bill does not apply to the state health plan. I will say that we have been working very hard with the state health plan to bring them into this legislation and do so in a cost-neutral way at this particular point. The state health plan obviously has a relationship with the PBM. They have they attempted or are attempting to negotiate some of these same provisions on their own accord. But we have been in conversations with several of the state health plan members that are responsible for this to discuss about whether it makes sense for them to be a part of this, and if so, what provisions would in fact cost money. For what it's worth, I mean, cost is a concern. I'm not particularly interested in passing legislation that shifts more cost onto the consumers and payers in this particular instance. So that is a goal to do so, which is why we've stayed away from the $10 script fee, prescription dispensing fee, and then pointing to specific pricing models that are being required or being mandated in certain circumstances. We've looked at other states to see what they've done in similar situations and see how the market has played out. I have not seen anything where the cost have increased as a result of some of these provisions in place. But again, I'm sensitive to the state health plan, and we are working hard to try and rope them into this cost neutral.
Thank you, Mr. Chair. And I'm concerned at both having to be the one that writes the budget, some for the state health plan and what its overruns are. But I do feel like in other bills, exempting the state health plan is just an attempt to hide what the cost would be across the board when we have an insurance company that's roughly 30% of the private insurance market in the state, covering 700,000 people. That we don't show what the cost would be because we have to pay those, so we merely exempt our own plan. But I'd love to see how this I think will impact private insurance as much as it would impact the state insurance. I thank you for the work you're doing on this. I think there is a fundamental problem that pharmacists are reimbursed on a retail basis when they are medical professionals, and we reimburse pharmacists for I call it their ability to count to 30 and put it in a particular bottle when that is not the work and the need of the pharmacist that is out there, and their ability to run retail, and quite frankly, independent pharmacists survive on their ability to sell sodas and medical equipment and walkers in their store, not for their professional experience in consulting with patients and physicians on potential interactions with drugs and others. I know we've talked about that in some other areas, starting to move to where some of that's where their reimbursement should come from. not a good strategy to have the profession of pharmacy reimbursed on some sort of dispensing fee or some sort of retail market of the drugs they sell.
Senator Ice, so I'll just at the very outset you made a comment that excluding the state health plan was an intention to hide potential costs, and I would disagree with that. That was not the intention at all, and not what we did in this particular instance.
I hope I did, and I clearly meant to say, if not, that other bills that have been out there, I believe that is the purpose of why they have been. I do not think that's what you're trying to do.
So the state health plan has been working with their PBM to incorporate a lot of these same provisions, and a lot of the payors have been at the table with this particular bill and very excited about some of the guardrails and the transparency, especially that are put into place with respect to PBMs and PSAOs. And I wanted to highlight especially that we're talking about the whole marketplace here with prescription drugs. A lot of times, especially last session, even this session, some of the other bills that are running through the House, we're seeing the PBMs as one of it. And I think you asked the question about, is there a contractual obligation? Well, there is. So if we're looking at the transparency and some of these protections in place, leaving out the PSAOs is a huge gap in the problem. I think that's why it's important for us to have that conversation with their role they play in this particular marketplace. Some of our neighboring states have taken a look at this with some success, and I think that's where we need to go as a state as well. But again, on the state health plan, we're working. It's 18 pages. It's one of the most complex marketplaces that I've ever looked at in my short time being here. I learn something new every single day with respect to how this one lever affects another one, and we're going to continue to work on it.
Senator Bayfield.
Thank you. Thank you for acknowledging that this is very complex, because that's what it feels like to my little brain. What is a PASO? I've never heard that acronym before, and what is the role that they play in this whole scheme?
Senator Sari.
I mean, it's a
PSA, and I just want to make sure I was correct on this, is a Pharmacy Services Administrative Organization. The Pharmacy Service Administrative Organizations represent the pharmacies in their negotiations with some of the other entities. And I believe, and I'm looking through my notes here, so 83% of independent pharmacists have a contract with the PSAO, and 75% of independent small chain pharmacies contract with PSAOs. The PSAO is on one side, the PBM is on the other side of the transaction in this particular circumstance. Again, it's something that not a lot of people think about, but they're some of our largest healthcare companies.
Follow up?
Yeah, follow up. Thank you. That's very helpful. Didn't know that. What comes to my mind, there's no fixing this, right, in this bill or really any other bill, but this just shows how insanely complicated our entire healthcare system is, and I will just offer that there are models out there that are so much simpler than this, if we would just entertain them.
Thank you. Any other questions from the committee? All right, we do have a speaker, Connor Rose. Connor, if you'll step to the microphone, identify who you are, and you've got a couple of minutes to talk.
I don't even know if I'll need that. Good morning, everybody. My name is Connor Rose. I'm a Senior Director of State Affairs at the Pharmaceutical Care Management Association. We're the national trade representing pharmacy benefit managers. At the outset, I do want to thank Senator Sari. This process has been incredibly collaborative, comprehensive, transparent, probably one of the better processes I've dealt with in the several states that I've worked in over the last few years, so I want to thank you for that. I think it's also important to recognize that this committee passed Senate Bill 24, and that bill recognizes the fact that North Carolina has some of the highest healthcare costs in the country. And so our concern and goal as this bill moves through the process is that we avoid any unintended consequences with increased costs, reduced access to care for patients, and trying to achieve that right balance to provide relief to some of the pharmacies that Senator Sari's noted. And I think he's done that with the inclusion of PSAOs and some of the requirements that are placed on them. So we look forward to continuing to work with Senator Sari and the rest of the committee. I'm happy to answer any questions if there are any.
Thank you, Connor. Any other questions from the committee? All right, is there a motion? Did you have a question, or do you want to make a motion?
I have two comments, Mr. Chair.
Senator Moffitt, you have the floor.
Thank you. I appreciate the work that has gone into this, and I understand why we're exempting the state health plan as you're continuing to work with them on, kind of getting the market equal with one another. I just think we have to be very careful with a me versus thee type of approach to these broad market issues. So again, thank you for doing what you're doing. This is very complicated, and I'm going to use a Helene reference as my second comment. We were doing just fine until the administrators showed up, and once they showed up, it got very complicated very quickly. Thank you, Mr. Chair. A motion at the appropriate time.
All right. May I read a motion that you will accept? A motion for a favorable report for the bill as amended, rolled into a new PCS unfavorable to the original, with leave for staff to make technical changes if necessary, and referrals to Commerce and Insurance, Finance, and Rules. This bill still has a long way to go, so we'll have a lot of opportunities to talk about it. Is that a good motion for you? All right, we have a motion on the floor. Is there a second? Have a second for Senator Waddell. Any other discussion? All in favor say aye. Thank you. Ladies and gentlemen, that is the conclusion of this committee. You're adjourned.